that you have sent us. My name is Amir. I'm a part-time endodontist with the prosthodontic associate and a full-time associate professor at the Faculty of Dentistry and head of endodontics at Mount Sinai Hospital. So for today, we want to talk about basically this relationship between pulpal and periodontal relationship. And we are talking about the main avenues of communication. The dental pulp and the periodontium are in fact very intimately related through several pathways that can be anatomical pathways, through the apical foramen, through the dental tubuli, lateral and accessory canals, or developmental groups, or through the non-physiological pathway, whether it's going to be a perforation or root fractures. So to briefly touch base on the anatomy and microscopic anatomy of such communications, the major one is obviously the apical foramen. This is the most direct route of communication between the pulp and periodontium, and it's the port of exit for bacterial and inflammatory byproducts that may exit the apical foramen and cause the pre-apical pathosis. Pulp inflammation or necrosis can extend via the apical foramen and cause a local inflammatory response and the bone and root resorption. It's also the port of entry for inflammatory byproducts from a deep periodontal pocket the other way, started from the periodontal pocket and gets into the pulp environment. The second most important is obviously very numerous in the numbers are the dentinal tubuli. They are basically extend from the intermediate dentin just inside the cemento-dentinal junction all the way to the pulp dentinal junction and run relatively straight courses between the periphery and the pulp. So we have the numerous number of these, although the diameters decrease with the age, but we are still talking about number per millimeter, square millimeters that would vary between 8,000 to 57,000 per square millimeters. The next could be the lateral and the accessory canals. And as you can see here in the slide, where we are talking about a direct pathway again that can contain the connective tissue and the blood vessels between the circulatory system of the pulp and the periodontium. And in fact, it's estimated that 30 to 40% of the teeth, they would have the lateral or the accessory canals. Other pathway of communication, or those who can contribute to this game, is the developmental grooves. These are mostly for the maxillary incisors, and these grooves are usually start from the cingulum, and yet they can mimic an endo or a perio problem. These are, again, to remind you, mostly in the maxillary incisor, there's a groove that usually starts at the cingulum and extend all the way to the apical portion. And obviously the bacteria can breach through the epithelial attachment and cause the periodontal pocket that follows the groove. So without addressing the both situations, then we are still in a trouble, because in one way, we can have endodontic situation that can be mimicked very easily by the way of the developmental group, and the other is no matter if we just take care of the endodontic problem and yet not address the developmental group, we may not be able to address the periodontal pocket that may happen in that area. So that's why we need to consider both type of treatment, endodontic treatment as well as the developmental group in such cases where we have the developmental group with an endodontic infection. Others contributing factors are non-physiological in nature. These are our mistakes in performing the treatment. Either we are having a perforation as part of our access, or we are having the strip perforation when we are doing the over-instrumentation into the endodontic pathway, or if you're just putting a post, an additional risk or restorative procedure, yet the one that is not being indicated or not being selected carefully for the canal of choice, or not placed in a proper way. So these associations could include the perforation in the root surface and cause a direct communication between the endodontic and periodontal environments. And obviously, the most devastating situation is where we have the vertical root fractures, which is, again, another direct entry and yet much more devastating in nature that would cause the loss of the tooth. So we are talking of the significance of this issue to be really related to the different environments in which each of these diseases is contained. For a pulpal disease, we're talking about the closed environment of the root canal system, and for a periodontal disease, we're talking about an open environment. So once we think about these two environments, in reality, the clinical expression can become very much similar, but yet it's very difficult in establishing a correct diagnosis and difficult in undertaking a proper course of treatment, the one that would become evidence-based and address the background problem that the patient has in this area. And obviously, the proper diagnosis would be paramount, because pulpal diagnosis in general, they are mostly reversible, yet periodontal disease, that could be partially reversible. So we're talking about a complex situation between the primary endodontic treatment or primary periodontal disease and combination of both, that we have an endodontic infection which has caused by periodontal disease, or endodontic infection that is causing the periodontal disease, and a true combination of this situation. So these are becoming mostly confusing for us at the clinical level, and to identify the pathway, although it can be confusing, but the very easy way to consider and find the best treatment strategy is to begin asking ourselves not to be in rush for making the decision, not to fall into the trap of the radiographic interpretation, because that can because it can easily be mixed between the two environments. And to do our due diligence, the key to the careful examination and the history taking would become as the way for us to diagnose the actual background problem. So to look at the diagnostic procedure, as I said, doing our due diligence with respect to the history, the chief complaint of the patient, the visual examination of intraoral and extraoral examination, the radiographs, the pulp vitality testing, the periodontal examination, and then put the whole story together. So let's try to simplify this. The idea here is always we want us to have our first rule with respect to endodontic area. Do we have a tooth that have an endodontic problem? So we need to establish our pulpal diagnosis first. Are we talking about a vital pulp or a necrotic pulp, or at least some response that may give us into the direction of a degeneration of the pulp, especially for a multi-rooted teeth? Now that we have the answer for the first question, then the second question would become as whether or not the tooth or the patient have a periodontal problem, either locally to that tooth, locally to that area, or more generalized for the whole mouth. And then the third rule, if we are not totally sure about the answers to the previous two questions, we have to always consider running the most conservative treatment or no treatment and the follow-up for the patient. And the fourth rule is always to follow up. That's the way for us to make sure that the diagnosis had addressed the best course of action for the patient, and we have the final solution. So to quickly show you some example, if you're dealing with a primary endodontic lesion, these are the situations where we have a caries, restorative procedure, a traumatic injuries. These are the most common causes when we get the primary endodontic problem. So the pulp would be necrotic, or at least would give us some sort of an abnormal response. And typically we would have the resorption of the bone more so located apically because of that direct route of the communication through the apical foramen. In most of the situation, the pattern of our periodontal pocketing is more so becoming as a format of a narrow, isolated pocket that we start from somehow normal, or at least within the range of the normal limits of the pocket, and yet we then get into an isolated pocket. And these are usually, especially in the multi-rooted teeth, these are pretty much the sinus tract that are being established as format of a deep pocket, and through which the drainage is being established. Yet they can still resemble a grade 3 through and through forcation defect resulting from the periodontal disease. So to show you as an example, the pre-treatment radiography of tooth number 4-6 in the slide number A, where you see that we have the radiolucency in the forcation area and around the mesiobuccal root. And further, you also notice that there is some degree of opacity in that forcation area, which is the alloplastic graft in the forcation to which the lesion is non-responsive. So slide B is showing the post-treatment radiographically, where the canals have been cleaned and obturated, and then we can see the progress of healing in slide C and D. So this was endodontic in nature, and yet the periodontal treatment was performed without any success, because that's not the environment that we have to aim to clean. And by the way of the root canal retreatment, the problem has been addressed. You can see another one here, a primary endodontic lesion. You can in fact see a J-shaped radiolucency. Many of us would consider that to be a cracked tooth, and yet without having the detection of the crack and through the root canal treatment, you can see the healing after only a 1 year post-obturation. The second situation is our primary periodontal lesions. Here, the etiology, we are talking more about a progressive nature of the clinical attachment loss to be beginning more so in the sulcus and migrating to the apex as far as we have the deposits of the plaques and the calculus, and those are causing the inflammation. So we have the loss of the surrounding alveolar bone and periodontium, loss of the clinical attachment, tooth mobility, and eventually the formation of the periodontal abscess during the acute phase of the treatment. So here, the most important question is, the pulp should be vital. If we are talking about only a periodontal problem with not so much of an attachment and extension to the pulp, then the pulp should give us a positive response, in special to endo eyes. That would be the most specific exam and the vitality testing in order to address the response of the pulp. Yet, once we look at the overall story, we are looking at accumulation of plaque and calculus. So despite the other situation for the primary endodontic, that we are looking at caries, we are looking at defective restoration or deep restoration encroaching onto the pulp. Here we are talking more as the primary nature and the primary etiology to be periodontal. So the pocketing here would become more so similar to a generalized increase in the pocket depth of the attachment loss and making that crater form of the pocket loss, as compared to the endodontic lesion, where we mostly have the isolated deep pocket in only one section of the tooth. So to simplify this and to go again with our 4 rules to establish the endodontic diagnosis, then to look at the pulpal periodontal status, then if we are not totally sure, to look at the most conservative approach, and finally to follow up. So to show you an example, this is from a journal article where they performed, because of the lesion, as you can see in the radiograph, they started with endodontic treatment. They faced with a normal pulp. You can see that in the histology slide just underneath. So with just addressing the endodontic aspect, which was totally an unnecessary treatment to begin with, obviously that focal lesion is not going to heal. And that was basically a wrong diagnosis, a wrong treatment plan. So the treatment plan would become as periodontal treatment plan. A periapical lesion of endodontic origin, we have to remember these are not occurring in the presence of the normal vital pulp, so we should not do the root canal treatment. Depending on the extent of the periodontitis and on the patient's ability to comply with the periodontal long-term treatment and the maintenance therapy, then our prognosis would become different, and that would exclusively become dependent on the outcome of the periodontal treatment. So you see here an example. probing in a typical periodontal lesion. We're talking about a radiograph here that is showing obviously clinical attachment loss. We are looking at the bone lesion located more at the crestal area, and we are not really looking at any other evidence of pulpal environments that would be affected. No cavities there, no deep restoration, so it's a good margin of the crown, and yet we are looking at that bone loss. And if we go through our 4 simple rule, and the first rule here is, well, pulp is vital. The periodontal treatment has been rendered, and you can see 2 years down the road, a recall radiograph of a successful periodontal treatment, and the tooth remains to be vital endodontically. So what if the situation gets worse? What if you have a necrosis of the pulp that is not causing the inflammation and hence the clinical attachment loss of the periodontium, or the other way around, that we have the crestal bone loss, the periodontal bone loss, and establishing the endodontic lesion by the way of our communication through the dental tubuli, through the lateral canal, or through the apical foramen. So the situation is getting much more complicated, yet still our approach would become the same 4 steps to establish our endodontic diagnosis, to establish our periodontal diagnosis. If you are in doubt, then to address the most conservative approach, which can be as simple as a scaling or as simple as a pulpotomy or pulpectomy, depending on the nature, and then follow up as always. So if you have a primary endodontic lesion with a secondary periodontal lesion, or the other way around, it doesn't matter. As you establish the diagnosis for endodontic environment, the response to our vitality testing would be negative. And that's the time that we are starting with our root canal treatment, or at least we go on a conservative approach of the root canal treatment, doing a pulpectomy, packing it with calcium hydroxide, putting and placing a good interim restoration, and then follow up the patient in a few months to just double check whether or not we can get a better environment to give some degree of the healing of periodontium, so that we can then and only then plan for periodontal treatment. The prognosis would depend on whether or not the root canal treatment would be adequate, and whether or not giving that to be adequate, then only and only depending on the outcome of the periodontal disease. So if we have a single rooted teeth, the prognosis would become usually poor in such situation when we have loss of clinical attachment loss. Yet once we have the multi-rooted teeth, we have a better prognosis, because not only some of the roots may not be affected, or at the same time they may be affected, but not all the way to the same degree, and we may have a better stability for the patient. So here are some cases that you can see endodontic treatment was rendered first to get some degree of the healing, and then down the road, once after a year of waiting to get an adequate amount of healing for the apical portion and the periodicular portion, then the referral to a periodontist is happening to address the focal lesion. See another excessive situation here, a tooth that may be considered hopeless. By conservative treatment, you can get some degree of the healing, and then having the periodontal surgery to be addressing the remaining problem. Other examples are shown here in this slide, where we start with endodontic treatment, get some degree of the healing, and finally have, after 1 year of waiting and checkup to make sure that the endodontic treatment is working well, then we are looking at the final xenograft and a non-resorbable membrane placement following the debridement. So in the summary and the points of our take-home message, the clinical expression of both the endodontic and periodontal diseases can be very similar. The difficulties in establishing the correct diagnosis and to render the proper course of the treatment. And we have to always treat the underlying disease and its secondary complications. So that's the major point here, that we need to make sure whether endodontic is major in nature or whether periodontal is a major in the nature. The resolution of the defect would be highly dependent on this primary source and the chronicity of the lesion. Overall, depends on the perio. We are talking about a closed environment of endodontic area, endodontic environment, which is much more forgiving as compared to an open environment that is being subjected to the bacterial attacks through the oral cavity. So the prognosis, again, depends on the perio. The greater the perio involvement, the poorer the prognosis would become. And the more of the lesion to be the result of the pulpal disease, then we would have obviously the better prognosis. So although this situation can be complex, we define some easier steps, not to rush ourselves, not to fall into the trap of the radiographic presentation, and do our absolute due diligence with respect to the history taking, to the clinical, radiographic, endodontic, and periodontal examination, and then following the same 4 rules for all these scenarios. To start from endo environment, establish whether or not the tooth does require endodontic treatment or not. Once we have that answer, then move to the next one about the periodontal question. The third rule, if you're not absolutely sure, then do the most conservative treatment, or just simply put no treatment and follow-up. We can always give some time to the course of the disease to make sure we are providing the best treatment of the best indicated treatment for the patient, and then follow up no matter what will happen. So to establish your pulpal diagnosis first, look at the status of the pulp. That's important. If the pulp is vital, obviously we don't need to have root canal treatment. If the pulp is unhealthy or necrotic, then we do a root canal treatment first. This would be mostly reversible. That would help us to get quick resolution. And then we follow up and we look at the periodontal situation then, only if needed, following the root canal treatment. And once we have some degree of the attachment apparatus to be formed, if there is a need for periodontal treatment, then we can move on. Ask always yourself at the end of the day whether or not we can provide the best possible course of action to the combined treatment. If we're looking at a financial burden for the patient, we are looking at cost, comorbidity with respect to the time that the patient has to put, the progress of healing. So for some of these cases, especially the very advanced cases, maybe the best way to look at is just to take the patient out of the absolute immediate need of the pain, which mostly for the true combined lesions or for the situations that the both endo perio are involved, is to provide a minimal endodontic treatment to get the patient out of pain, to provide some scaling and root planing, provide some follow-up time to see whether or not there is any healing involved. If that's not the case, maybe the best course of action, especially for advanced cases, would be extraction and then look at some other replacement. So that was one of our series of the PACE on the frequently asked questions.